Oh, shoot.
So welcome to the Littleton Board of Health,
Yeah.
Wednesday, February 10th, 2020, virtual Zoom meeting. Read the Zoom rules. The town of Littleton began conducting remote participation / Zoom meetings pursuant to Governor Baker's emergency order suspending certain provisions of the open meeting law on March 19th, 2020. Since that time, unanticipated legal concerns related to the open meeting law have been brought to our attention by town clerk. Those concerns were supported by the Attorney General's office and confirmed by town council. One concern is that the chat function allows a parallel text conversation to a board's public meeting. Chat is essentially running commentary that is occurring but is not moderated or followed by the chair. All participants and listeners may not be aware of the comments being made because some meeting participants join by phone and do not see these conversations. Another concern of conversation is conversations between residents within the chat room, which is not incorporated into the public record. In response to these concerns, the town will implement the following changes, which in no way prohibit any member of the town from participating in discussion and sharing information during a public meeting, and will ensure that all listeners and participants have equal access to this meeting. People that join the Zoom meeting are set so their microphones are muted. If you call in by phone, please use *6 to mute or unmute your phone so that the meeting will occur in an orderly fashion. We ask that people who join keep their microphones on mute so background noises do not interfere with the meeting. If you wish to participate in the meeting, use the raise your hand function available on Zoom, or if you call in by phone, dial *9, which will activate the raise your hand function. The meeting host will notify the chairperson of the raised hands, and the chairperson will determine whether and when to allow public comment. When called upon, participants may unmute and state their name and address. After speaking, we request that participants return their microphone back to mute. And I am going to try and turn my video back on. Sorry. Good. So Jim has to leave at 7:25. We have a new co-host. Ed Mullins is here, guest host. But go ahead, Jim. Why don't you give us your update, if you don't mind?
Sure. So as of last week, at the end of last week, the governor made some changes to occupancies at facilities that became effective on the 8th of February. Essentially, the capacities that had been at 25% are now at 40%. And that includes restaurants and close personal services. And I think one of the important things to note is that on those capacities, both for restaurants and close personal services, the staff doesn't count as part of that 40%. And the close person, so in the case of restaurants, capacity is set by seats. In the case of close personal services, unless there is a occupancy that's determined for the space, and then the 40% would be based on that. They're allowed to have 5 people per 1,000 square feet in the building. For restaurants, some of the things haven't changed, even though the capacity has changed. Masks are still required, except when you're eating. The 90-minute kind of time frame on the tables is the same. 6 people per table is the same. And in a restaurant, you need to be seated. So standing at the bar is not an acceptable situation. So capacities have expanded in light of the numbers going down, but some things haven't. So the gathering limits haven't changed. Indoors, it's still 10. Outdoors, it's still 25. As far as numbers goes for the town, I sent Mike some numbers this morning. Littleton for the 2-week running was up just a little bit. So I kind of pulled the numbers each week just for Littleton to see what the numbers were. Setting back the week, so these are all, I think they end, so they end on a Saturday. So January 2nd, there were 35 cases in that week. The 9th, there were 26. The 16th, there were 26. The 23rd of January, the week ending the 23rd, were 20. And for some reason, the week ending the 30th, it had bumped up to 28. So not quite sure what's happening. Throughout the district and kind of in Littleton in general, the numbers had been trending down. The district still seems like week over week, they're trending down. So that's what I have for an update at this point.
Great. And when was your senior flu clinic?
So we had one today.
COVID test. You had one today?
Yes.
Oh, great.
We did one last week. We did one this week. We're doing the first responders, second dose clinics next Wednesday and Saturday. And then we hope to do another senior clinic on the 24th.
And that's working out okay with the Council on Aging and the signups and everything?
They're doing a marvelous job. I mean, we really could not do what we're doing without them, because it takes all our time to get people through the clinic. So the added, addition of having to register people at the clinic, it just wouldn't work. We wouldn't be able to get the number of people through that we can. So it's working quite well. Great.
Like I said, I have a correspondence. We can send that to you too. So, but I'll read it later. But yeah, okay. Mr. Yap was very impressed with your clinic today. So happy that it was local.
Good. Well, it's interesting. He had called me last week. He used to be on the board and was kind of asking me where clinics were in that. So he must have saw the press release and got right on it. And so he called me the subsequent week and said, "Hey, I got in." It's like, great.
Good.
So it's good that it's working out for people.
Good. Does anybody have any questions for Jim at all?
I have a question for him.
Sure.
I saw on Facebook that I think some people were saying that whoever brings a senior for a vaccination, they can also get vaccinated.
So in the lovely way that the governor makes his announcements, today he had a press conference in which he announced that caregivers who bring somebody so if a senior has a caregiver and the caregiver is over 75, they're eligible to be vaccinated. What probably they didn't put on Facebook is that they're eligible to do that if they register, and if they register at one of the large sites, one of the mass vaccination sites. So we had people coming through the door this morning after the press conference saying, "Hey, I'm a caregiver. Can I get my shot today?" And we were all kind of scratching our head until they said, "No, the governor made the announcement." It's like, that's nice. He didn't tell us.
So the caregiver has to be over 75?
Well, the person needs to be over 75, and this person needs to be the caregiver for the person over 75.
Okay.
So it's a little more nuanced than maybe showing up on Facebook, because when we first heard it too, it's like, how's this going to work with what we're doing with the senior centers? And my understanding from reading the document, the press release, is that they're eligible at these mass sites. And again, it kind of makes sense. A lot of times seniors need help getting through these mass sites, where our site's a little more user-friendly because it's much shorter distance from the parking lot to the door.
I'd like to suggest there's another reason that's been pressuring the governor for this, and that is that there's a fair amount of transmission that goes on between, we'll call it younger folks that live with older people, and that there's quite a bit of, shall we say, outgoing transmission, maybe not in quiet little Littleton, but elsewhere. And it's turning out to be a source. So this is a good move. However, the fact that we're still under restriction, or that we're still working through priorities, indicates that we still have a vaccine short, because if you think about it, why are we doing priorities?
Right.
Okay, so the virus has still got us.
Well, why aren't they giving shots to the 20-year-olds, or the ones that have the biggest, that are out and causing the most cases?
So my understanding from the state's kind of goals on this is that their goals were to try to get the healthcare folks done so that we could keep all the healthcare system open, then to reduce excess death. And so that, the 20-year-olds, if they get it, they might not even know they had it. So to your point, yes, they may pass it because they don't have it, but it's those people who get it and may die that they're really trying to make sure they target so they can reduce death.
Great. Anybody else have a question? Kevin?
Jim, can you just speak a little bit to the vaccination process for call it teachers, and when we might see that sort of coming down the pipeline?
We get that question a lot. So if you look at the state's vaccine plan, they're in phase 2, and they're in the third prioritization in phase 2. I'm told there are about 1 million people who are 65 and above. And so the first 2 groups in that are those over 75, those over 65, and those with 2 comorbidities. And then there's this big group of people that include retail workers, teachers, public health workers. There's a whole bunch of people in that. So I'm not sure when we'll have enough vaccine to get down into that next phase. I think it's going to be well into March, but that's just my guess based on how things are rolling out at this point.
So got it.
Maybe Anthony, did you have any idea on vaccine distribution at all?
Well, Jim and I have spoken. I actually organized two meetings. The second one was this past Tuesday with the 17 communities that Neshoba Associated Boards of Health represents. Because we feel a couple of things that we feel that there's an inequity. So Neshoba gets 100 vaccines, Jim?
That's what we've been told.
Yeah. So Neshoba gets 100 vaccine. Neshoba represents 17 communities, somewhere in the vicinity of, I don't know, at least 120,000 people combined, maybe in those 17 communities. And yet Acton next door to us gets 100 for their Board of Health. So we're not on a fair playing ground, and the managers and the meetings that we had on Tuesday was with the administrators and managers of the 16 communities in Devons, as well as our state delegation representatives from across the region too, to try to resolve this inequities that we're getting with the vaccine counts. Honestly, I think that Jim should be getting 1,700 a week, and Littleton should have 100, just like Acton, just like every other community out there that is doing it through their Board of Health. So, we're working hard to try to, I know the legislators wrote a letter to the governor, and then the administrators, we're penning a letter that'll go out tomorrow, trying to advocate for more vaccines for Neshoba, as well as trying to create a super site here in our area, so we don't have to travel to Fenway Park or Foxborough or Danvers. Is there one in Springfield yet, Jim?
Yes.
Yeah, so this area is kind of a, we call it a desert, a vaccine desert, and we're trying really hard to address that. So a lot of stuff's been going on. Jim was part of the meeting on Tuesday, so hopefully we can advocate for more vaccines for our region.
The
Great.
delegation was out at the clinic today to kind of walk through it. Jamie and Sheila Harrington, Rep. Arcerio, and Rep. Sina. So
Awesome.
So we have the ear of some folks, so we're going to try to get the ear of the governor now.
Good. All right. I know Jim has to take off, but does anybody else have any other questions? Mike, do you have any questions or comments, or?
Not unless we can open up a vaccine production facility, right around the corner, or, that's probably the only solution available.
And that's well above my pay grade, well above it.
Okay. All right. Thanks, Jim.
All righty. I will talk to you later.
Okay. Thanks very much.
Thank you. See you later.
Thanks. Katrina, do you mind waiting? Because Mike Pontanella's here. I asked him to come in tonight to give us a brief idea of how the school testing is going. Do you mind waiting?
That's fine.
Okay. Thanks for coming, Mike.
Hey, you're welcome.
So I understand you said today was the second day of testing?
Tomorrow will be the second day of testing. We're testing the cohort A on Mondays and some staff, about half the staff, and cohort B will be tested on Thursdays and the rest of the staff.
And no results yet because of the way.
Not that I know of. I think they got them, like we would have expected to get them, but I'm not in the loop on a day-to-day basis getting updates on that. I expect that we will get some information tomorrow night at our meeting, but they won't have the results from the second set of tests by tomorrow night. They'll probably have those on Friday, and then we're going on break next week, so we're really only going to get 2 days of testing, and then we go on break, and then we're going to kind of restart. It's actually good, I think, that's going to happen, because it gives us a week of 2 days of testing to shake out the logistics and the process for collecting the samples and getting them into pools and sent along, and then we'll shake out some bugs and hit the ground running when the students and staff come back from the February break.
If the 6 weeks that are going to be allowed, that it's going to be free, will we get 5 weeks after break also?
I believe that's the way it works, yeah, but I'd have to double check the actual the fine print.
Right,
But
okay.
that's the way we understand it.
Good. All right. Does anybody have any questions for Mike Fontanella? Good. All right. Thanks for the update, Mike.
You're welcome. We'll be happy to talk about it in more detail when we get our own chance to look at it and see how it's going. Really, this is very, very preliminary. We're excited, but it's nothing meaningful has happened yet.
Right.
We haven't, as far as I know, we haven't given any of the Binax Now rapid tests. We've only done the pool testing. So that's another facet of it that we'll be very interested to see how much work that is to manage, but we just haven't gotten that far down the road yet. So very preliminary, baby steps.
And any, how many people signed up or allowed their kids to do it?
So right now we
well
have, like 500 something families have registered. We're looking for closer to 800, but again, we're not reading too much into that just because it was a very quick turnaround. So we expect that more people will sign up once we get back from break, which is perfectly fine. That's certainly allowed, and we don't have a problem with that. Again, just the breakneck pace at which this was implemented, I think, caught everybody a little flat-footed. So we're not trying to be reacting in any particular manner to the beginning of this. We'll see as we get a little farther down the road. We'll be able to make a better evaluation of good, bad, or indifferent in terms of level of participation, level of infections, positive pools, et cetera, et cetera.
Great. All right. Anybody comments or questions for Mike Fontanella? And I guess, Ed, anybody got their hands raised at all?
I don't see any raised hand.
Okay, great. All right. Thanks, Mike. Go watch some basketball.
Yeah, got extra work to do.
All right. Katrina?
All right. Hi. All right, there's my slides, right?
Yes.
All right, so as usual, we'll go over the state and we'll do some local, and then there's some changing things with coming down the line. So I'm going to try to rapidly review things. So these are the graphs of the 4 main metrics, the trend lines. Statewide, everything, cases and test positivities have returned to about the same level they were just at Thanksgiving. And number of hospitalizations and deaths per day have declined, but they're still higher than they were at Thanksgiving. So this is looking at testing. The number of tests remain high, stable, which is great. And then that actually, you can see the test positivity after following the holidays just keeps going down, which is great. So the trend between the cases and this, I'll do the cases next. Cases are also trending down. Like I said, that's about the same. We now have about 2,200 cases reported each day, and that's about the same level we were at for Thanksgiving. And the 14-day incidence rate is 48.9 per 100,000 this week, whereas 2 weeks ago it was 59.4. So again, that's a reduction, and that's a good sign. So test positivity declining, cases declining, going in the same direction. Those are good signs. Of course, I didn't show you that, did I? So there's the cases. And then we've got hospitalizations and deaths. And so remember that those rollbacks that were just lifted in capacity limits and things were meant to try to reduce the pressure on our healthcare system. So it is nice to see that the hospitalizations have declined. The last 7-day average is trending lower, and it's now about 1,600 hospitalizations a day. That is, however, still higher than the 950 at Thanksgiving. So we're not quite back to the same level in terms of hospitalizations. Hospital and ICU capacity have both declined as well. We're about 83% of hospital beds occupied and 74% of ICU beds are occupied. But again, those are reductions, which is a nice sign. And the numbers of deaths reported on a daily basis is about 55 per day now. Again, it was higher than at Thanksgiving, which was about 40. So again, everything is declining down. So that is an excellent sign. But we're still, for hospitalizations and deaths, above where we were at Thanksgiving. And we just loosened those capacity limits. We've increased them a little bit. So it'll be interesting to see what's going to happen in the next coming weeks, especially with a school break next week. So if we're looking at Littleton, this is the graph from last Thursday. So cases as of reported last Thursday's report. So these are for, this last bit of data is from January 17th to the 30th. We had 39 cases reported last week. 2 weeks ago, we had 59 cases. So you can see the decline here in town, which is great. Test positivity last Thursday was 2.7%. Again, that was lower, which is great, but this is still the 11th week in the red. So if you look at the rates per 100,000 for overtime, the trend you can see across the state and all the areas that we track has been trending down since the holidays, December holidays, and which is great. You can see Littleton has kind of flattened. It could be that we're just smaller, so we're seeing changes quicker than the other sites, which kind of average over each other. But that's something to keep an eye on. And if you look at Jim's report this week, I expect this flattening to remain in place. But again, everything kind of trended down. So Littleton's rate last week was 28.6 per 100,000, and that was lower. So that was good. So this is the test positivity for Littleton. We had 1,471 tests, which is actually a 10% increase from the prior 2 weeks. This was, again, data from last Thursday. And our test positivity was the 2.72%. Again, that was lower, almost 2% percentage points lower. So our cases declined or flattened, sorry, our cases flattened last week and they're flattened again. So we're lower than we were 2 weeks ago, but when you look at last week, we're kind of like a flat trend. So we'll see what happens with the break and everything else coming up. So this is Jim's sneak peek when he peeks into Maven for us, just to, so you guys can see what we anticipate tomorrow. He reported 43 cases today. And 2 weeks ago, that was 37. So we're around the same. It's not a significant difference. So we'd say flattening, stable. We are stable. So we're going to be comparing to 37 when we talked 2 weeks ago. So slightly higher, but about the same. We're kind of holding steady. Unfortunately, we're holding steady at a level that's closer to where we were before Christmas. Whereas the state, when you look at the state's numbers, are returning to that pre-Thanksgiving level. So we have not quite returned to that level yet. For whatever reason that is, our cases aren't declining quite as much as the statewide numbers are. So this is when you take just the number week over week, the number of new cases week over week. To date, we've had 432 cases. That's we're doing pretty good. We're still under 1,000. The red arrows, though, mark the weeks following each holiday in the state since the reopening started in June. And you can see that, like, each time there's a holiday, there's July 4th, we had a bump on a state level, or our town level. We had Labor Day, we had a slight bump. We had Columbus Day, we had a bump. And then we had Thanksgiving, Christmas, New Year's, Martin Luther King. So compared to the week before, there was a little bit of a jump each time. So the nice thing is we've declined each time too, but the pattern across the state, across the nation, is that whenever there's a holiday, you see this little bit of a jump as people socialize and their typical patterns change. So we are looking at President's Day weekend and a school holiday week, a break week, where people are not going to be doing their routine business, like their routines. So we expect, given our history of bumps along the way and what we know about household spread, is that I expect to see the the same pattern starting when we come back from February break. I would like to be proven wrong. So if anyone wants to prove me wrong, please be really good next week. So this is just some of the stuff coming out. So the variants, I know I talked about this 2 weeks ago. These are still evolving situations, the 3 variants, and they're concerning. And all 3 variants now have been detected in the US. The UK variant has been detected in Massachusetts, and it's predicted to be the dominant strain come March. So we're getting closer to that point. So hopefully our mitigation strategies are strong and that can help reduce the spread. So just like what that means, what I mean by that is that the new variants are still airborne respiratory diseases. They're still transmitted in the same ways that the original virus is. So if we use the tools in our toolkit, we're going to help reduce this or slow the spread of COVID. So wherever possible, we're still talking about masking and distancing and trying to get your vaccine if you're eligible. And, the schools are testing, things like that. These are all great layers to our toolkit. So if individuals, especially on break, can think about adding masks and things to their activities, that would be really helpful. So speaking of masks, the last time I was here, there were some questions about the recommendation to look at your mask quality and fit, especially given that the variants are here and they're more transmissible. So conveniently today, the CDC released a new study, this new information about mask quality and fit. They actually started reporting things on masks in November, sometime in November. And then they've kept adding to the information on the website about masks over November, December, January, and now today. So the information that is being published on the CDC website is really robust now. And the reference list with all the studies is growing. So it's pretty strong. So today they released this study, and it was in lab experiments, but they were measuring putting a cloth mask over a medical procedure mask or the surgical mask, or taking a surgical mask, which has the gaps on the side, and knotting them to try to improve the fit around the face, doing one of either of those things. So the double masking or the tying the knots to improve your surgical mask fit decreased exposure with the airborne particles by 95%. So this is really good improvement if you can improve your fit, or if you don't mind throwing another layer into your cloth mask. Everything helps, right? So this is also from the CDC website, and this kind of just goes through it again, like they don't want you to use the medical grade masks, leave those for healthcare workers still, but you want the properly fitted mask, something that's snug around your nose and your chin with no large gaps, made with a breathable fabric, like cotton, multiple layers of a breathable fabric, because you want to get the air to go through the fabric and to be caught. It's like an obstacle course for the virus, if you will. So again, tightly woven fabrics, 2 to 3 layers. And if your mask has a filter pocket, throw a filter in there just to help. And they give the don't do's as well on this slide, which actually haven't changed. So given that CDC has been frantically coming out and posting new things lately, it's like there's a lot of stuff that they're updating. And one of the things that the news is reporting is that they're anticipating some new school guidelines to be posted at some point this week. As of this slide kit, they hadn't been posted yet. So I do think, given that we are talking schools, we're talking testing in schools, there's discussion about whether we can, in the schools, whether the models can be changed up a little bit to get more kids in schools more often. There's a lot of moving parts to these discussions. There's a lot of intricacies, and I think it would be worth having just to update you as the Board of Health on that data, just so that you can understand what the current guidelines are. Oh boy. So for some reason, this happens every time. So this is, these are the health notification letters that the school sends out every time that there's a case reported among the school population. Now remember that testing right now is symptom-based, or if somebody has a known contact and the parents report to the school, and then the school does contact tracing with our Neshoba Board of Health and things like that. So these are the blue lines right now are the cases reported, the number of letters, the cases reported in the letters of number of students who are in the building, or staff, students and staff combined. So you can see that we hit Thanksgiving and we had this flurry of activity. The red is actually if the letter stated there was a close contact to a case, and this green one is if they had to move, they used the mitigation strategy of moving a classroom to remote for 2 weeks as a mitigate to prevent spread. And then anything in yellow is in a remote student or a remote week at school. So right after Christmas, we had a week of, this was Christmas vacation, and then we had a week where the schools were remote for the week, and then they came back. So you can see that like we hit Thanksgiving and we've kind of hit this, we have some weeks we have nothing, but then we kind of been getting like 4 cases a week for the last few weeks. This is an incomplete week. We had 1 case on Monday. Usually the letters come out, and if you think about it with timing with the weekend, we usually get notifications on Mondays and Thursdays from the self-reported cases. Now, I need to be clear, this is not the testing program, the pool testing program that the schools are doing. That is going to be, I don't actually know how they're going to report that. I'm assuming there'll be a separate reporting strategy, but these are the cases reported by families to the school. It is my understanding that they are the keeper of that data. So whatever they make public is what I would have access to. So that's something you guys might want to talk to them about. So the other thing, this slide right here shows all the mitigation strategies that our schools are currently using. I will say that this, if you think of this as the layers of cheese, all of these green boxes represents layers of cheese that the schools have put in place. It's a pretty good toolbox of mitigation strategies that they've put together. So, you know, that's the 6 feet of distance, the masks all the time. They started pool testing. There's cleaning, there's policies about close contacts and staying home if you're sick, things like that. These are all great things that have helped keep our cases low in our school. I mean, to date, we've only had 36 cases. So this is, I think this is partly because of the evidence of how our schools have reacted. You can tell we don't have vaccines yet. We don't know when the teachers will get access to them. Kids will come later in the year or next year. And we are actually doing full school days. When kids are in school, they're there the whole time. So that we're not limiting duration of time like some of the other schools send kids home after at lunch, so they don't have to eat in the school property. So we're not doing that, and we haven't had an issue with that, which is awesome. So this is just a few snapshots from the CDC's guidance on school operations. This guidance was originally created in August, and then it was updated December 31st. And then this website today says it was updated February 3rd. So it didn't go through any changes between when school started and, you know, halfway through the year. And now we're getting the new CDC director and the staff are busily updating things. The news, like I said, is reporting that the guidance is going to be updated again, given that the new CDC director presents the COVID update on Monday, Wednesday, Friday. I'm not sure when they're going to release that information. So maybe they'll release it tomorrow to discuss on Friday, but it will be interesting to see what changes when they do that update. But my understanding is based on news clips is that it's expected to focus on COVID mitigation strategies in schools. So the masks, the distancing, the hand hygiene, ventilation, cleaning, things like that. So it'll be interesting to see what they change and what they don't. So this is also from the CDC's website. And as we're talking about schools, our schools may be changing things up a bit. I think it's really important for everyone to know what the current guidelines are. And that I've also noticed some confusion based when people only look at the headlines or only look at the first paragraph of an article. They miss the nuances about various things. So this is where it's important to go to the source documents and see what's actually there. So the CDC currently presents school opening guidelines as a continuum of risk, and they lay it out with the lowest risk being keeping students and staff fully remote to the highest risk when there's no mitigation strategies in place at all, and then various levels in between. And within each level, they describe the mitigation strategies to be applied. So Littleton schools, like I just showed you on the other slide, use a number of mitigation strategies. They have a hybrid model. There's 6 feet of distance, masking. They're really some in the elementary schools, they have cohorts that are classroom based. Middle school, in high school, they do more mixing, but they have more distance in those because of the hybrid model. So when I look at these guidelines and know what our mitigation strategies are, it looks like Littleton falls somewhere in the some to medium risk categories, depending on which school you're looking at, which is great. We did a really good job at using what we could, using every mitigation strategy we could when we didn't know what was happening. So now we're hopefully with the testing program, we will have some more information to help figure out how to adjust this. So I also want to point out that the testing guidelines do not currently talk about differences if you have a testing program in place. So it'll be interesting if they include something like that when they update these. So the other thing that that keeps getting referenced in the news and in as people are, I'm seeing it on Facebook, social media, things like that, as people are trying to understand how can we get more of the kids in schools more often, because education is also a priority. So what can we do to adjust things here? Is that people are over and over, there's these 3 studies that get quoted, and the CDC director herself references these studies as she's speaking. So what I think is really important, again, is to know what these studies actually report, what they measured. So we look at their methods and then their results so that we can compare them, because what is missing often from the discussion is the mitigation strategies that the schools used. They just said there's no spread and that's all good and let's just go all full in. But there's actually more to these studies than is usually reported in the news. So the 3 studies, all 3 of them, there's one from the CDC's, which is the Wood County, Wisconsin one. There's an ABC Science Collaborative out of North Carolina that was with Duke. And there's 2 schools in Tennessee. I can't remember which university assisted them with this, but there's it's in a preprint. Those are linked on the slides. I unfortunately didn't reference them so everyone can view them, but we can make that available. So these are all kind of very different settings. There's rural, there's urban, there's variation in them. One of the commonalities for all of these is that there were high rates of COVID in the community. So that's something to keep in mind. All 3 studies used masking, 6 feet, closed cohorts or tight groups of people that they tried not to mix. And the 3rd study used pooled testing. The first 2 studies did not test at all. So you can see that, so they measured cases. The first 2 studies used the same testing strategy our schools have used up to this point, which is that symptomatic or close contacts will get tested by the state, and then that's reported into the school. And the 3rd study used their pooled testing, a combination of pooled testing and those self-reported cases that arose through the symptomatic close contact kind of testing scheme. So what they found is that 1 to 4.6% of the students and staff in those communities ended up being a case over the time period that they measured. So remember, that's with mitigation, such as the masks, the distance, the 6 feet, the cohorts, the testing. So when they used all of those things, the number of people in their population, the school population who became a case, was low. And then they also measured secondary transmission in the schools. So in school transmission, they're trying to understand that. The first 2 studies used only reported cases that arose from among people who were close contacts of those cases that were originally reported in the schools. And the 3rd study actually used their testing to try to measure that. So the in-school transmission, so of the cases, the total cases, 3.7 to 11% arose from an in-school transmission, which is 2 or more cases that were linked to the school site. So again, it's not nothing, but it's not wildly high. We're not like transmitting to 80% of people once you get one in there. So those mitigation strategies help to reduce the spread within the school. The one study that used the pooled testing did report that there were more in-school transmissions in those schools, and that they were finding more asymptomatic students, especially among the lower elementary school ages. So the younger the kids, the more asymptomatic cases that were arising and they were catching. Those would have been missed in the first two studies because they weren't doing pooled testing. So overall, the conclusion for all three of these studies is very similar. They concluded that in-school transmission events were low when comprehensive, and I quote, comprehensive mitigation strategies are in place. And they used them to varying degrees, but they were still there, they were present. The good news is that the mitigation strategies that Littleton schools are using are very similar to these that are described in these studies. And I think our own experience supports this data actually, that we've had 36 cases to date. We haven't had any known in-school transmission where, you know, our mitigation strategies are strong and they're helping to protect our community. So it'll be important to keep an eye on the science and the changes to the CDC guidelines as they're rolling out rapidly right now, but also as I know the school committee is planning to start talking about maybe making changes to the hybrid model and how they get more kids in the building. So this is something important to keep in mind. And I just really want us all to be on the same page and understanding the science behind it, because otherwise the headlines don't tell the whole story. So things are great when you use mitigation strategies. So the other thing, we're going back just to everyone. You guys know the vaccines are being rolled out. If you have a chance to get one, if it's your turn, please get one. The 75 plus group, I mean, we've talked about it. Jim's, got a wait list. The town has a wait list. Anthony is working on getting more access in this area. That would be amazingly helpful, especially if people didn't have to go far. I did hear that the governor said that if somebody brings a senior to one of the mass clinics, then they would, on the second dose for that senior, they would be eligible to get their first dose. I'm not sure how that's going to work. It's unclear to me. But I do know that if you're going to the state's website to try to get an appointment, they seem to release them all at the same time, like at noon on Thursday. So maybe that's a time to try to get on the website to get an appointment at a mass site if you're looking to get one. And then just as always, it's worth to keep masking and distancing and doing everything you can until you can get that vaccine yourself. And then lately I know I've been feeling it, and I'm pretty sure because everyone I talk to is really, expressing tiredness and just I'm sad or frustrated, or I'm really angry because I can't do the things I want to do. I think we're approaching a year from when the state closed in mid-March, and I can see the fatigue on everyone's face, and I just want to make sure that people are kind of taking a break and taking it easy on themselves and recognizing that those angers and frustration and sadness, everyone's feeling them. And if you need a help, to just call your doctor, ask a friend, somebody just to lean on, because I think it's really important right now that we take care of ourselves and seek help if we really need it. So I just want to remind everyone to do something for yourself every day. And that is it.
So Katrina, I have a couple of questions. The pool testing, is that going to affect the amount of testing being done in Littleton by the state's, when you talk about test positivity, is that going to affect our numbers at all?
I would anticipate it would. So what I understand is that the pooled testing numbers end up going into I'm not actually sure. This is a really good point. What I'm not entirely sure, and we'll have to see and track over the few weeks, is how they're going to get the denominator from that. But if you're considering 10 people are in a pool and they stuck in the pool, and if you have one positive, that positive does get entered into the system. Jim will end up getting them. The contact tracers will end up contacting them. And they do get reported down to the DPH level. So I am assuming that the other 9 also get counted as a test because they technically are tested. But I'm not entirely sure how that works. So we're in this period right now where I'm not sure how this is going to work for the town's test positivity, but we will be able to see those cases in the town's case report.
Okay.
It is, so we are testing more people, so, and we're not going to get many positives in the numerator, so it could be that our test positivity will decrease. It's just a matter of, I'm not sure how they're reporting it yet. I will keep an eye on the number of tests that are reported week over week, because if we know there are 500 kids that got tested this week and next week's number jumps to 1900, then I will know that they counted every single kid as a test. It's something that we'll just have to keep an eye on, and I can see if I can ask questions of the people I know.
Great. Mike, did you have questions or
Yeah,
comments?
yeah. I was just wondering. Katrina already knows that variants are my current hobby. So, if and when B117 arrives as the dominant version in March, and assuming that the mitigation efforts are partially responsible for the decline we have today, what's your best guess from what you've seen about B117 of how the state will experience it? And if you can, I mean, I won't ask you to project it to Littleton because that's not fair.
I can't project that, actually. I'm not even sure I could do it on a state level. I know there's been last I looked, there was 6 cases in Mass that have been detected, but I don't know how often they're doing the detection. So I don't know. I'll be honest, I don't know this answer to that, Mike. I wish I did.
So in other words, I'm just making the assumption that it becomes dominant in Massachusetts because that's what it's supposed to be, the dominant strain. So you're saying even if the mitigation, so it's difficult to know what will happen even if the mitigation efforts that we currently have are operational. We don't know enough about this in the United States.
So it's my understanding based on the research in the UK is that it's 50% more transmissible, which means when you let your guard down, you're more likely to get infected with, it's just easier to get through. So if you're not wearing your mask, or maybe your mask isn't the best quality, or you're just hanging out with your friend on the couch because that's what you've been doing, this is the time to maybe put some distance in between you and put a mask on when you're hanging out. When you let your guard down, you're going to be more likely to get infected at this point. So what I hope we don't see is that that this doesn't change the settings, like schools where we've put all of these mitigation strategies in place. I think it's going to take advantage when we don't, in those areas where we don't have all of these strategies. So that's our own personal time. That's if you're going to the grocery store and you have you could add a better quality mask just to reduce your risk. If you, anytime you're in a setting with groups of people, it's really good at this point to just think, what can I do to be better than I was yesterday? So yeah, it's just when you let your guard down, it's gonna get you.
Louise or Kevin, do you guys have any questions or comments for Katrina?
I was just curious, is there any data on the variant and the asymptomatic cases of the variant versus the normal COVID-19? Does it still have that same characteristic?
That is a really good question, Kevin. And I haven't heard of any differences in the proportion of asymptomatic cases or symptomatic cases. I don't know, maybe Mike has, but I also haven't been looking. So I can look into that.
Just curious.
Yeah, no, it's a good question. If it causes more people to have symptoms, then we'll be more likely to catch them. But again, our youngest people are less likely to have symptoms. So it all kind of, we'll have to see on that one. That's a really good question.
And the only place we could get the numbers to make a study or to make an analysis worthwhile is the UK, and that place is a mess.
Yeah, they didn't have masking. They didn't have distancing in their schools. They just had them full open and no mitigation in there. So
in fact, we privately call it the Great Variant Breeding Ground in the West.
right, Louise, did you have anything you wanted to ask Katrina? Okay. Great, thank you, Katrina. Still working on the COVID. Did Kevin, did you have anything that you wanted to add, Kevin Davis?
Yeah, nothing this evening to add. No new news. Bum.
Okay. All right. Do we open it up to any questions from any of the attendees at all? Or does anybody have their hands up, Ed?
I see no hands raised. Oh, hold on. One just popped up. John just asked to speak.
Okay, John,
I don't have a last name, so.
John, if you can state your name and your address, please.
It's John Kurzwick, 171 Hartwell. Just a comment on the variant. Yeah, I don't know which way this is going to go, but I think, you know, looking at the UK cases right now, UK cases are down 50% from peak. So whatever variant that they have, the transmissibility is not showing up in their daily case rates. Let's put it that way. And then, of course, the daily case rates that we have here in Massachusetts, those are down 50% since January. I would say, though, one thing of caution that I am concerned about is, because I keep going with what Shaman says, which is absolute humidity, and that's peak transmissibility when absolute humidity is at its lowest. So I would say we're not out of the woods, but it's curious that the cases have essentially crashed over this period. So, you know, the only thing I can think of is that this coronavirus is acting very similar to other coronaviruses, which show, you know, very sharp seasonality, and that was shown in the Hive study. That was a longitudinal study, 8 years in Michigan. So, to me, the data keeps showing that the number one factor in this transmissibility is really the seasonality. You know, it doesn't mean go ahead and take your mask off and all that, but it really is amazing to just see this thing dropping the way it is. And I'll be curious to see over the next 4 weeks if we get a little bit of a bump up here, because dew points in Boston have been pretty low over the last 4 weeks. So we'll see. But I'm encouraged by seeing the cases go down. I at this point, I personally would not be too concerned about the UK variant because it's not showing up in their particular data. But that's just an opinion, and I just wanted to voice that. So thank you.
Great. Thanks, John.
Madam Chair, we have another hand raised.
Yeah, Katrina wanted to respond to that.
So I'm also encouraged by the cases going down in both the UK and here locally, but I hope there's a humidity thing to this and it will help us in the end. The good weather will help us. But I think there's often people discount or don't count enough the mitigation strategies that we used to help bring those cases down. Those capacity limits that were put on businesses from December 26th till now I think it was an important part of why our cases went down. We restricted people moving and mixing and sitting in places for long periods of time together. And I know that means people hurt economically, but I think that's I think people discount the social reasons, determinants of disease, and these social determinants of disease time after time keep coming up as things that you put something in place and it changes the case rate. And it's the same in the UK. The UK was extremely locked down. Even schools were closed this last time. So I'm not surprised that cases have dramatically dropped there. It will be interesting to see as they open things back up, what happens to their case rates. So again, people got the message that there was a big deal and they changed their behaviors and they didn't go out and they didn't go, the places are closed, so they're not going places. So just like with our graph of like after every holiday, we have a bump. It's the same thing. Is that social patterns of disease are really important. I think we sometimes discount them for other biological and plausible explanations. They all work together. Those biological plausibility explanations and the social determinants of disease are both important, and we can't discount the social piece just because it's convenient.
Okay. Somebody else, Ed, has their hand raised.
Amy's on next up.
Go ahead, Amy.
Hi, this is Amy Tez, 117 Whitcomb Avenue. I just wanted to comment, I guess now piggyback on what Katrina just said. I think I'm concerned. I mean, I'm by no means an expert in any of this, and I'm concerned that when feedback comes in about from like the previous speaker, you know, that we're hearing information that may or may not be accurate. And I think the concern about the variant is that we really don't know hard and fast yet if it's more deadly, and it's looking like it might be. And I think when we're considering moving forward and making decisions as a town, you know, I think it's important to continue to have discussions about keeping measures in place where we can. And I'm hopeful and kind of interested to see in the next few conversations how this plays out, because I certainly have seen a little bit of buzz about getting the kids back in school for more time, maybe with some of these measures reducing. So I'm hopeful that as a town and as this board continues to discuss this, that we can use the information we've got in front of us, as accurate as it is with what we've got, to make those decisions and keep safety as a priority, rather than just kind of figuring it may not be as severe as, I don't know, as some news outlet might report it to be. So thank you for letting me make another comment today.
Sure. Yeah, I don't think the school committee takes it very lightly. So just to open it up for just opening it up sake. So, but Mike's not on anymore. So I guess we'll talk about that tomorrow. Go ahead, Mike.
Yeah, I'd just like to let Amy know that you're not alone in being concerned about garbled information filtering out into all the usual empty and filled spaces. But in regard to the variant that's being projected to dominate the United States in and around March, there's no evidence yet that it's more deadly. The evidence so far from actual cases is that it is, shall we say, more transmissible, which simply means that if you happen to come in contact with the virus that happens to be that particular variant, its success rate is greater. So remember, not all virus variants are created equal. Some are more efficient for, let's say, landing in the back of your throat and being successful in getting themselves going. Others just can't do it. So this one happens to be one of the ones that do it with, shall we say, more success than the current virus. And the other encouraging word is that up until a few weeks ago, the United States was sort of stuck with 2 labs in the United States that could do the kind of analysis necessary to identify variants, regardless if it's the one for the UK or someone coming from South America. So now there's a real, what I call, system for, and more robust, it's growing more robust every week, to detect, as to survey the virus, the nature of the virus population that's in and around the United States. And that information, I think folks like Katrina can use in reinforcing our need to take the mitigation efforts that we have in place seriously.
Great. Thank you, Mike. Anybody want to comment anymore?
No more raised hands.
Okay, thanks. All right. So thanks, Katrina. and Kevin Davis. I guess we'll move on to correspondence on the agenda. I have a letter to that was sent in today from Peter Yap. I'll read it. Dear Mr. Gareffi, Board of Health workers and volunteers, I want to thank everyone for their participation in the clinic held recently at Devon's. It was an impressive event and how well organized and smoothly it went. The biggest thing was to have a clinic in our area. People here that are going through the COVID-19 website were given appointments in North Adams, New Bedford, and other places far away. I couldn't even make an appointment. I talked to hospitals, doctor's office, and others hours and hours to no avail. But when I heard of a local clinic, I was thrilled and was even more thrilled when I learned that I was scheduled to get the vaccine. Fact is, I think I let out a big yell. So to all involved, a huge thank you. Keep up the good work. So thanks again. This is Peter Yap from Littleton. So I was told Jim that he got a little attaboy, but I knew that we were going to read that later. So anybody else have more correspondence or anything like that? Okay. We have minutes approved, but we didn't have a meeting last week, so I think we're all caught up with that. And so member comments. We have a continuance tonight of 83 Mill Road, so we're going to do that next Wednesday on the 17th. And in terms of the library reopening, Jim has talked to Sam, and as long as they are following sector specific workplace standards, he thinks that it's fine for them to open the way that they were planning. Okay. Anybody have any comments?
Lisa, do you want me to mention the mischief I've been making elsewhere?
Yes, please do. We love to hear your mistress, your mischief. Sorry, Mike. Tell your wife I said I'm sorry too.
She's already glaring at me as it is. So that's thanks a lot, Lisa. Anyway,
Sorry.
that's an interesting slip, Lisa. We'll have to have a chat. That's all right. Okay. Gee, how can I top that? Anyway. Yes, I can imagine. Anyway, just so you folks know, I'm just going to bring you up to date. There's no policy. It's just a quick overview. Several weeks ago, actually, it seems like years ago, the topic of reviewing and assessing and looking to make changes to make the Littleton Board of Health more effective, more efficient, more useful to the town now that the town has grown to where it is. I just want to let you know that the pandemic has helped me a lot since I started on this, because there's nothing like a crisis that stress tests an operation or a committee, or even especially a Board of Health. So it's been possible to collect a lot of information, but there's a lot of crucial information still missing. But it's very obvious that we are going to move forward with this, and including engagement with the community at large to make sure that they understand it's their Board of Health. But I just want to remind everyone here that one of the guiding principles is that a Board of Health legal, as far as the state's concerned, we are required to have a Board of Health. So the alternative of not having one is not in our cards. The question is, what form or type would it take? The second thing I want to mention is that, as Jim Gareffi mentioned earlier, we're part of our what we call a Board of Health is actually a relationship with a particular group, a very competent group, the Neshoba Boards of Health. They are not necessarily, they don't belong to Littleton per se. They belong to the various, what we'll call subscribing communities. So obviously, does that format fit us? If not, what's the alternatives? Do we tinker with it? There's a whole bunch of issues there. And obviously the other one is the support and maintenance of an effective Board of Health operation. So obviously we'll be looking for where we are now in terms of what goes in and what goes out. What does it cost to have what we have? And what can we do if there were better resources available? Could we quote, do more of meaningful healthcare, not healthcare, but public health to the town? So I hope gradually in subsequent meetings, we can start, as it were, the process of setting up a system where we can have a discussion ongoing with the community and all the other stakeholders, which includes many functions that are in town hall. So we don't exist in a vacuum. There are many overlapping functions, and I'm sure we'll, as it were, sort it out, hopefully come out a little bit better than we were going in. And any ideas that any of you have that what you'd like to see, I'm looking at Ed, I'm looking at Kevin, I'm looking at Lisa, I'm looking at Anthony, I'm looking at, and Louise, I'm looking, please don't hesitate to let me know where I should be looking or what I should ignore. Thanks a lot.
Thanks. I talked to Diane and she said that we can go ahead and pick a date for a retreat for the board. So we just have to, it can't be next week because at least next Monday through Wednesday. I think Monday is a holiday, but weekends, evenings, we'll just have to decide on a date that we can all be free.
Do you visualize this retreat is going to be virtual?
Nope, we can meet at the multi-purpose room.
Okay,
As
thank
long
you.
as there's no more than 10 people. So I don't know if we want to text each other and see. Monday nights are good for me. You guys can think about it. I know I'm just springing it on you. So weekends are doable. We would just have to get somebody to open the building for us. That would be Ed, I guess.
Ed, actually, talk to Nancy, because what we can do is the building's now fobbed, so they can go in room 103. We can, with the time they're gonna go in, just have that door opened. Yeah, but you don't have to go there. It's gonna be automatically done through the computer. So we could talk about it. Well, you'll be all set.
All right, excellent. So think about a time that works for you guys, and we'll try and figure out what works for all of us. I don't know how quickly you want to do it, Mike, like in an emergency basis, like ASAP or?
Well, I don't know how shall we say, this is the first time in months we've mentioned the topic. I just want to give the folks here a chance to absorb it. I'm ready to go anytime.
Okay.
And Monday nights are fine with me, but as long as I have some advance warning.
Okay. It wouldn't be this coming Monday because it's a
Right.
holiday.
Right.
So does everybody think the Monday after that would be okay?
If I may, Madam Chair, the following Monday is a select board meeting as well.
Okay. All right. All right. So let's try and get to a consensus and try and pick a day. Okay.
I guess we got to find out when the room's available.
All right.
The select board is still meeting remotely, but at times I'm required to attend. I would like to be, and I would like to be present for your meeting one to assist in the moderation if possible.
Okay. All right. Okay. Let's look at our schedules and see when it works well for everybody. Okay. Any other member comments at all? Oh, okay. And any public comments at all?
No hands raised at this time.
Okay. All right. Has anybody heard from Gino? Okay. All right. So who wants to make a motion? We ready to adjourn?
Make a motion to adjourn.
I'll second.
Second.
I seconded.
Okay. So Kevin Baker,
Kevin Baker, yes.
Louise Nichols,
Louise Nichols, yes.
Mike Zeldin,
Sheldon, yes.
Lisa Flanagan, yes. All right. Thank you.
Thanks, everybody.
Have a good night.
Thanks.